Hey, apologize that I didn't post this sooner, but it'll be okay. It'll be all right. So we're going to talk about the somatic symptoms. What does that mean? Have you heard of this before? In what way have you heard of it? Well, like, how were you familiar before reading about this today, or what kind of comes to mind as you think about somatic symptoms?
Is it like the physical, sensations that come
The physical sensations that come with psychological disorders? Yeah, I think that could be one way to put it. Yeah. Anybody else? Like, have you heard of the term psychosomatic? That's psychosomatic. What does that mean?
Coming from your head?
Yeah, we kind of say that with some judgment, right? Like, well, I don't know, it almost seems like there's a just to that should come in front of that. Oh, that's just psychosomatic, something like that. Why do we do that? Kind of invalidates, like that's not real, is almost what it feels like. But I mean, I don't know, smash your thumb, that's fine, right? It's like, oh shit, that hurts. But this is, so it's going on in your brain, which your brain's a pretty important organ, I would say. But yeah, we kind of place this limitation on it. And I think the DSM revisions have attempted in like renaming and restructuring this to reduce again some of the stigma that's surrounded with somatic symptoms. Like hysteria was something that would have been in this area, right? You're just hysterical, they're kind of out of control, that kind of thing. But we'll see some of those words kind of going forward. So we'll be talking about a few of these: factitious disorder, conversion disorder, somatic symptom disorder, illness anxiety disorder, and then psychological factors affecting other medical conditions. And so this is some relationship, like when you're not doing well, what's some physical manifestations like of that? Anybody like have physical symptoms when they're mentally not doing well? Give me some examples.
Headaches.
Headaches, yeah.
Stomach aches.
Stomach aches, absolutely. Yeah, feeling kind of sick, a little bit.
Lethargic.
Feel tired, yeah. Any other ones?
Back pains.
Say that again?
Oh, back pains.
Back pain, yeah. I definitely feel like if I start getting stressed, a lot of times my back will become more sore. Yeah, absolutely. So, are those factitious disorders or conversion disorders? Not necessarily. But a lot of these things can be exacerbated. So things like ulcers sometimes act up when people are more stressed. Gastrointestinal issues, those are things that might pop up. But the first one we're going to talk about is this factitious disorder. Anybody know what else that was known as? AKA Munchausen? You heard Munchausen before? This is the real bit called factitious disorder. Like, oh, Munchausen, yeah. What's the famous one? What's Munchausen?
Isn't that like when you think that someone else is medically ill and it's like Gypsy Rose or Mom? Something like that. Did you ever see?
So there's two different, so we've got factitious disorder, which is a self-imposed version of that. So they make themselves sick. And then we have factitious disorder imposed on another. That used to be called Munchausen's by proxy. And that's probably the famous one where you make other people sick for their attention. Yeah.
Well, when I was looking up some information for the paper, for the class, I came across something called corporeal bound disorders, where it's like how a lot of, or some of the disorders that we have, other cultures, we don't see them, or other cultures don't have certain disorders that we won't have. Would that be the same thing?
We have different rates of prevalence of somatic disorders, and there's cultural differences there. Why might that be? I think that's a really good point. Or what cultural factor might that depend on?
Depends on how advanced the culture is, I think.
What do you mean by advanced?
So we're more advanced, there's bound to be more problems as far as intellectually and education. Like this thing being more advanced, there's more, I'm trying to think of the best way to describe this. In a culture that's like third world, they don't have the same day-to-day struggles we have. So we might have more pressure in different areas.
Okay, so you're saying because of different stressors, that's gonna have an impact on it.
That would make more sense for us to have more somatic issues.
So so for somatic, so you say that there's more somatic issues as there's more stressors in the society?
Yeah.
Okay.
So I was also reading too that some cultures, they interpret stress differently. So
Yeah.
with even like third world countries or whatnot, I don't know, there's a word for it, whereas you get better after stress, like it makes you better. I don't know, they just interpret it different.
Sure. So sort of the view of psychological distress is gonna impact how it's expressed in the culture, right? I think, is that what you're saying? Yeah, okay. So depending on the amount of stigma of psychological disorders as well, that's gonna impact it. But if I can express like, hey, you know, I'm really stressed right now, I'm feeling really overwhelmed, and that's an acceptable thing to express, we would probably see that expression. But if it's less acceptable to experience stress or to be overwhelmed or something like that, to place that onto another person, we'll see more conversion disorders and this kind of thing. So we'll talk about that in a minute. So first, we'll take a look at this factitious disorder. We may not watch the whole thing, it's like 10 minutes long, but this is an interesting case.
I remember when I went home from the hospital, I didn't want to go. I felt like I was going to cry to leave the hospital. I didn't really know why. I didn't want to leave.
So she began to invent ways to get back into the hospital.
Like I took oven cleaner, rub it on my arms, and get a chemical burn. Put whatever was under the kitchen sink in some orange juice and, drink it to see what happened.
Her first attempts didn't make her sick enough to be hospitalized. Then she tried Drano. That worked.
I was hospitalized more than 30 times. I lost count after that.
All for things you had done to yourself.
Yeah, well, like when the bladder started getting better, or at some of the treatments that help it. But what I do is, inject bacteria into my veins. I contaminate the IVs.
So you would
inject things into the IV lines.
like dirt from the floor or feces?
Anything that, bacteria causing. Things that contain bacteria.
And didn't you fear you might die from these things?
I always thought I would get well. There was a point, like, my bladder ended up, they took it out. It went too far. And it's gone now. And
Who wants to go to a hospital? I think hospitals are frightening, confining, creepy places. But to people like Julie, the hospital is a comforting place. Think about it. It is a very nurturing environment.
How are you?
It's a safe, womb-like place. A bit like being a child, home with loving parents. Julie will not talk about her parents, but she says the hospital's nurturing gave her the strength to attend college and keep a job.
it was the caring, like nurses will sit down by you and talk to you about family things. And after you're in that same hospital, like 10, 15 times, they know you. They know you from the cleaning people to the dietitian. They all know you, and it's like it's a family feel.
So a family feel that you needed and weren't getting in your life.
Well, yeah, because that little bit of encouragement, a little bit of caring can carry you a long way.
What Julie has is called factitious disorder. What it is, simply put, is disease forgery. People fake being sick or actually make themselves sick, all to get loving, nurturing attention from doctors, nurses, family, and friends. It's different from hypochondria, in that hypochondriacs just think they're sick. People with factitious disorder have actually made themselves sick. In its most extreme form, it's called Munchausen syndrome. This refers to people whose lives are totally consumed by this compulsion to get themselves hospitalized. That's rare, but thousands of people are thought to have secret lives like Julie's. Many doctors say on any given day in most hospitals, there's at least one patient like her. As far as we know, Julie is the only person who has been willing to publicly admit what she has done.
When I was doing it, and this is going to be hard for you to understand, very hard, I felt like what I got out of it was good for me. It was a coping skill.
Why would someone do this to themselves?
First of all, we have to recognize that the patients themselves may not know why.
Dr. Mark Feldman just wrote a book about factitious disorder.
Now, some patients have been victimized by abuse earlier in childhood. But a factor that I think is most important in a lot of cases is long-term, severe, but unrecognized depression. We know that depression can lead to desperate behavior, including suicide, and certainly factitious behavior is desperate behavior.
And you don't know why you have this giant need.
Well, see, I don't feel it's a giant need. I feel like all I need is a little. Doesn't everyone need a little?
But other people don't do this to themselves to get it.
But when people need something, they cope in all different ways. I feel this is just one way. Like some people cope through alcohol, some people take drugs.
Julie was admitted to one hospital 15 times. When she thought the staff might be catching on, like many with factitious disorder, she just moved to another town. Later she moved again and did the same thing in a new hospital. Her employer's health insurance paid the hundreds of thousands of dollars in bills. A survey of others with factitious disorder found they averaged 9 hospital admissions a year. One man ran up $6 million in bills. People with factitious disorder have done some incredible things to themselves. One woman, to hold the attention of her surgeon, repeatedly rubbed feces into her stitches to reinfect the wound. Others have injected themselves with feces or starch.
What do you think? Where's it come from? What are your guesses?
Where does what come from?
Factitious disorder. Like, how might that come about?
So would it just be like various of things that was trying to get into the hospital, or would it just be one thing? Like, let's say I don't know, like a certain disorder, so they try to have it.
Well, it could be various things. So she tried, the really point is to get that type of care.
So is that what they all try to get? The type of care, they'll just do a bunch of things?
Yeah.
So would it not come from their childhood?
Yeah. They do see that there seems to be some childhood trauma of some sort that's going on. Like, one thing is that she won't talk about her parents, right?
Mm-hmm.
I'll probably give you a little bit of a clue what was going on. Like, what do you think her parents were very nurturing?
Yeah, probably neglect.
Probably not.
Neglectful,
Probably
She
neglectful.
refused to talk about them.
Yeah.
Well, she said the main reason she did it was because she wanted to care for the nurses. I think that very much answers the question.
Yeah, that they
Felt good. Yeah. Anybody ever have like a really positive experience while getting medical care? No.
I invited my nurses to lunch after I came off anesthesia.
Okay. Because you were still like high or?
Yes.
Gotcha.
I don't remember doing that.
Oh my God. Yeah. Anybody have good experience?
Yeah, I feel like they're all usually pretty nice.
Very nice. So, like, imagine that contrast. Like, you come from a place where you're really not getting love and appreciation, maybe in lots of different areas of your life, and you discover this one place where, like, you're accepted and loved, you experience that love, and that feels good, right? She's like, hey, I just want a little bit of that. She didn't get any, probably anywhere else in her life. And It was an okay price to pay to get that type of care. So they may start off with sort of something traumatic where they don't get a lot of love, where they don't get a lot of recognition. Maybe something legitimate happens, they break a leg or something like that, they go to the doctor, they receive care, and they're like, holy shit, this is the first time I actually feel love from somebody. Well, now put on your behaviorist hat. What just happened? It was reinforced, yeah. So this pain was really reinforced. This traumatic experience or getting sick was reinforced with positive with receiving love.
So is the thought of them like it's their job as doctors and nurses? Do they not think about that? Like they're supposed to take care of you and
Yeah.
so, or is that just kind of put to the side?
Because I think it's not very common. I think once it's recognized that, you know what, hey, our love and care sort of is making things worse,
Mm-hmm.
and then care kind of shifts. It's not doing the same thing for that person, so she just moved to the next hospital. You know, if it's super common, yeah, I think we probably need to do a better job of sort of recognizing, like, you know, hey, is this a possibility? So more than, like, if you were just to guess, like, hey, was it something that somebody did to themselves, you're more than likely you'd say no. You know, usually that doesn't happen. Do you have to be careful to it? You know, if you work in that kind of setting, probably. You know, if they said, you know, probably one person on average, it was something that's inflicted if you're in a hospital setting. But I think the main thing I want you to get away from this is that it's access to something positive. The way that you said it was like, it was her coping mechanism, right?
Mm-hmm.
But a healthy coping mechanism, probably not. And we'll talk about treatment here in a little bit. So you can start thinking about how would you treat that? That's weird. So here's that factitious disorder. It's imposed on self, that was her version. But it can also be imposed on somebody else. That's Munchausen by proxy, and what that was known as. And so in movies, a lot of times you'll still hear it called as Munchausen. That's what they're referred to. What's going on with that? Why would somebody do that?
For which one, self or for another?
For imposed on another.
I guess for another, like, this is based on what I read from my family violence class, that mostly the parent wants more attention, and they use their own child for that, just to cause harm and everything, just to get like especially in today's society, using social media. So the more views, the more compliments, and like they like that.
So again, sort of that behaviorist view of kind of what is reinforced, right? And attention is a positive reinforcer. Like, we add it and it feels good. So we can see more of that kind of thing happening over time. Do you think they're related? Like, from a psychological standpoint?
I think it roots from the same thing.
Yeah. So my wife used to work at a vet clinic in Florida, and I think she saw, like, the way she described it, she saw a lot of this kind of sort of stuff. Not that they would make their animals sick, but there was a lot of folks that maybe didn't have children that would get a lot of attention from going to the vet clinic. Anybody else work at a vet clinic here? Yeah. So same kind of thing, like getting some positive attention. So I think to me it feels very different because, you know, you're putting it on somebody else. But the same thing, but the commonality between the two is that it's this attention seeking, getting love, getting belonging through the illness kind of thing.
So for it to be imposed, would it be like me telling you that you have this
could, I guess, involve just kind of convincing them, like, hey, you know what, there's something going on, but this is actually making the person sick physically. So you have folks that are giving their children things that make them ill.
So that they can come to them.
Yeah, and so it's either then they'll take care of the child and can sort of get that connection. My mom said one time when I was younger, she wished that I got sick. Right, your mom. Why did she wish that?
So she could take care of you?
Yeah, she's like, I was always just, running around throwing shit, and she's like, oh, I just want to nurture my child again. Then I got really sick, and she's like, I don't know, just want not that sick, like, I was sick for like, I had the flu or something like that. I was like, oh shit, that was sick. I don't think she made me sick, but maybe, no.
Do you not have any like unexplained illnesses or something?
Not when I'm around, not around her, only when I'm around my, no, I'm just kidding. Yeah. Alright, questions about factitious disorder?
Can it be like other than like parent and children? Like,
Sure. Yeah. I'd have to look at the diagnostic criteria again. I'm sort of wondering, like, if I do this with my dog, would that fit criteria? What do you guys think? What do you think?
I think it says it does.
It does? Does it say, does it mention pets specifically?
Yeah, and, yeah.
It does? That's awesome. I've never seen it. Like, I've never treated anybody for it or anything like that, but.
I guess you would see it right there,
Well, that's what I'm saying, like, maybe.
Have you heard of the Gypsy Rose case?
I think so.
So I'm pretty sure her mom had Munchausen's by proxy. Like she shaved her daughter bald and was in a wheelchair, was allergic to sugar, had all this weird stuff, and then
Yep.
she killed her mom.
Yeah, yes, yeah.
There's,
They make a series or something?
Yeah.
There's
Yeah.
a movie
there's a movie. Yes,
There's a
with
movie?
Joe King in it.
Okay, yeah, I did.
There is a movie. I don't. What is it
Yeah.
called?
I don't know what it's called.
I remember watching it over the summer.
I think it's called Mama or something.
Alright, tell you what, take about 3 minutes, I was gonna do this later, but let's do it now. Take about 3 minutes, 3-4 minutes, talk with the neighbor, decide on what treatment might look like for these folks. Just for this one, we closed on self. Silent treatment? You got one? You got one? Alright, what do you have? How do we treat this?
Intense therapy.
You're trying to order me out. What does that therapy look like?
Working through those childhood trauma issues, trying to get over that so you don't need the coping mechanism anymore.
Okay, yeah. Zap them every time they try to inject themselves with.
I mean, there's gotta be better ways to deal with that.
Yeah, it'd be difficult, right, to treat. So I think the point is like, yeah, treating just the symptom in itself. Now, you probably want to keep a behavioral thing. Anybody else, what do you have? What kind of treatments?
thinking behavior modification, trying to change the reinforcement of what they're getting from the hospital and
Okay.
finding a different path for them.
Yeah, what would that look like?
I have no idea.
Don't know, okay.
Don't worry about it.
That's fine, we're all back here.
CBT for those things.
CBT,
And maybe reinforce the positive behavior in treatment.
okay. Good.
Okay, we were in a therapeutic alliance, like building trust with a doctor to like at least help them like get comfortable enough to say like,
Yeah.
okay, you might need a little bit more,
Yeah.
more therapy or medications or something to ease them to like believe that, oh, they shouldn't get that much anxiety for like a little bit of pain or something.
Okay, so I've got somebody that really wants a lot of attention, or that needs some attention at least, right? Historically, they've gotten it through the medical profession. Now they've like, she accepted that this is something that she has, so she starts therapy. Anything I gotta be careful of?
What if she switches that reinforcement to the therapist?
Yeah. Probably something I want to keep in mind. I probably want to maintain really healthy boundaries with that person, because it probably could be really easy for that person to latch on to now that the therapy becomes sort of this new coping thing.
How would you fix that then? Because that's the point of the therapy.
Yeah, so she was talking about building a therapeutic alliance, and so that's a very, very fine line, right? And it can be very tricky. Any guesses
Could
how
you,
much
like,
you do with that?
More than one therapist, so that way you minimize the
Tag team.
opportunity.
You're in.
Like take the opportunity, like minimize the opportunity for you to get attached to just one.
Okay, okay. I like how you're thinking. Anybody else?
What
What do
about
you
group
think?
therapy?
I like it.
That way that there's more than one patient and they can't all attach to the same time maybe. And
Yeah.
also seeing the effect, I think here's another story, that's crazy, but it could also be very close.
So you're reinforcing sort of peer-to-peer
Yeah.
types of interactions rather than focusing on the professional interaction. What do you think about that?
Well, because in the video we just saw, she's not really getting attached to any certain people because she has no problem switching hospitals as long as she's getting the attention. So my concern would be how to not reinforce, like as long as they're getting attention, they're fine, they're gonna keep wanting it.
Yeah.
So how would you be able to treat it without reinforcing anything, without giving them that stimulus?
I think it's not a matter of not giving them the stimulus, because sometimes the best thing that, like, they're saying this is what I need, and saying no, well, because you need it, I'm not going to give it to you, is probably not the best approach. But saying like, how can we meet that need in a socially acceptable type of way is the trick. It's probably going to take a while. You know, this is probably not a 3-session type of deal.
What about like a group therapy setting?
Yeah, that's the thing what he recommended, yeah. I think group therapy can be really good. Having sufficient number of people that are willing to, that have factitious disorder specifically, so you probably are gonna look at maybe a different type of a group. So probably wouldn't be a group that is one sometimes groups are structured based on a specific diagnosis. Other times, you can have more of a general therapy group where you build it's sort of focused on relationship and growth building and stuff like that. And I think that probably could be a part of the treatment regimen, absolutely. Yeah, but I think that point of, like, we have to be careful on where does the lines, like, how do we make sure that the connection doesn't occur too much between the folks. So let's see how we did. Precise causes, maybe not understood completely. Research is pretty weak on it so far. Do we have a dependably effective? We don't yet. Again, because it's not that common of an occurring one, the research is a bit sparse on it. But some of the common effects of, like, how does treatment work in general, building therapeutic alliances, CBT approaches, having somebody that is caring but doesn't, is good about maintaining boundaries. Those are all probably important aspects of it. Absolutely. All right, we'll take next a look at conversion disorders. What do you know about conversion disorders? What does that bring up for you to think about, like, conversion disorders? driving in a convertible. What are we converting from? One lifestyle to another. Say more about that. Okay. Anybody else? Any other ideas? We're converting something psychological to something physical. That's sort of what that conversion is all about. Let's take a look.
Completely lost full ability to walk.
I rely on everyone to help me get food, get change, help drown myself out of the shower because I can't do it.
Very frightening. You just see your child go from a perfectly active teenager to not being able to walk, not being able to talk.
It's very hard, I think, for people to understand, for laymen, for anyone to really understand how it can be that patients can present with such significant, overwhelming symptoms when there's no physical cause.
Incredibly, doctors say there shouldn't be anything wrong with Adelaide teenager Holly Longford.
I was spasming out of control and I couldn't stand or walk. But as I got in for longer, I started to lose my speech.
16-year-old Holly has been living a nightmare existence for over a year.
It was really frightening having all these tests done and each test coming back negative for everything.
What did you think was happening to you?
I just thought something's really wrong with me, but what it is, I don't know what it is. And is it like, could it kill me?
Up until then, she was like any other school-going teen.
Going out with friends to parties, I played netball, touch footy and I danced.
But her world was turned upside down 14 months ago after a collision while playing netball.
And I came off the court crying because my back was in so much pain. And then the days progressed. I just got worse.
She saw chiropractors, physios and doctors, but no one could help.
I got admitted to another doctor and then he put me on fluoxetine and I had a reaction to it. So it sent my body off into a spasming seizure sort of thing, not being able to stop, and I couldn't walk at all.
She spent 2 weeks in hospital learning how to walk again, and despite countless tests and scans, doctors couldn't find anything physically wrong. For her mum Wendy, the unknown was frightening.
You just see your little girl deteriorate and they can't find anything, and I suppose that's the hard thing as a parent. You don't want to believe it's a psychological issue either, because you think, I can't fix that.
No one really understood it as well. They just thought it was like...
Alright, what do you think's going on? I'll tell you a little bit more here in a minute, but... You don't get it?
She got injured playing sport?
She had a collision. She had an event that happened during the sport, but then from that point on, she had the submersion of these symptoms and not being able to walk, stuttering, speech issues, those kind of things.
Because of that event that happened?
That's what they're saying is not the case. It was a starting event, but that wasn't the cause, is what the medical piece is showing. You look confused.
So is it possible that when she saw the attention she was getting, she just milked it and then...
Yeah, that's not what's happening in conversion disorders. The person themselves is not intentionally manifesting those symptoms. So it's not like she's pretending. That would be.
So she actually thinks that she's not able to walk.
Yeah, she is not able to control her body in the way that, from a physiological perspective, from the brain on forward, there's no reason for her disability to walk in her speech pattern.
So there's nothing there for that to be caused, but she just persuaded herself that, and then it happened?
Yeah, but it's not a conscious choice. So it's caused within the brain, but it's not like a conscious, like, oh, this is how I'm gonna do that.
How does it show up in the brain?
We see the symptoms. So,
Like, can you see where like the wires get crossed on a scan
oh,
or anything?
no, at this point, I don't think we have that ability to see that disconnection. I mean, we probably would see that the activation of those motor areas is not activating in the way that it should, but I'm not even 100% on that.
So like, what's there then?
What's what?
What's there then?
What's there? What do you mean? Like what's in the brain?
Like
All the structures are still there. They can have a quick recovery, is the good news on this.
How does it even happen in the first place?
Yeah.
It's just hard to understand because there's no physical reason that she shouldn't be able to walk and she can't walk.
Yeah.
So there isn't like something there that's debilitating her to not walk and not.
Other than her psychology.
So her psychology is subconsciously convincing herself that, and then it's actually happening.
Yeah, that would be a psychodynamic view of that, but yes, yeah. So we're taking the psychological issue that is going on. We don't know yet what's going on, and it is being converted to a physiological issue. Why might that be? Any guesses?
Do you think learned helplessness has anything to do?
Say more about that.
Oh, that's all.
That's all you got? Sounds good, yeah. You guys know what learned helplessness is? Yeah, so sort of learning that your ability to help yourself is diminished, essentially.
There's nothing you can do to fix anything.
Yeah.
Like in the beginning, how she said, I depend on everyone to help me get changed and shower and stuff like that.
Yeah.
That's what she said.
Yeah. I think in the sense that she was maybe unable to, like her brain as a whole system didn't have a lot of confidence in another way of expressing what was going on. So one view, sort of one cognitive view of this disorder is that it is an expression. It's not a verbal expression, but it's an expression of the psychological issue that's happening.
So what is the issue?
We don't know in her case.
Is there a chance that one day she'll just wake up and be completely normal?
There's probably something that will have to happen for that. We probably have to look at what is the underlying issue.
But she could recover 100%.
She could, yeah, absolutely. Absolutely. And she probably will. Let's keep watching for a minute. In a minute. I watched it. Where is my cartoon?
I was just a freak out and like almost a miracle that I recovered so quick.
But not for long. The spasming in the legs returned and she was readmitted to hospital. And that's when she was diagnosed with the mysterious conversion disorder.
A conversion disorder is a disorder where patients present with signs and symptoms of a neurological illness, such as having had a stroke or a seizure of some description, but where there's no actual underlying physical illness. Instead, it's the body's response to some underlying stress.
While it seems unbelievable, Dr. Andrew Court from the Royal Children's Hospital in Melbourne says it's very real. and illustrates the power of the mind over the body.
These symptoms are unconscious, they're not fabricated, they're not made up. They're something that the body and mind automatically does in order to avoid stress.
15-year-old Yana Tanska understands all too well. She's had the condition for 4 months. Hers was also triggered by back pain.
Some days I don't understand it, but like I understand what's happening, but you still wanna have a specific cause from it, like not just psychological, because it doesn't sound right. You just want something like a proper medical condition.
Health experts say little is known about the disorder and what triggers it. It can only be explained by psychological stress. But for Yana and Holly, two happy and healthy teens, it doesn't make sense.
Can you understand why?
It's your body's way of just saying it can't cope with stuff going on with your life, and it just needs to rebuild itself all over again, and that's really hard to accept.
I have no idea what it could have set it off, because at that time I was normal, I was happy, I was going out every weekend, going to parties and seeing friends.
While the symptoms aren't permanent, there's no quick or known cure, and there's always a chance it could return.
A rehabilitation program, it's a returning or retraining the body to functioning normally, which may involve physiotherapy, trying to work out what the underlying psychological distress is and be able to manage it and deal with it.
Nothing seems to be helping, so it's just hopefully time.
I will get better because.
Alright, what do you think?
So there's a stress.
Yeah. Now, the other girl, she said she didn't know like what that stressor was even, right? Like she's like, it seemed things were fine. She started having some back pain, and then she started having these symptoms.
Do the symptoms have to be extreme to this extent, or can they be like smaller symptoms to still be considered conversion disorder?
Conversion disorder has got to have that neurological. It has to look neurological in that sense. So yeah, we do have to see specific classes. So
you can
the somatic symptom disorder is probably more kind of what you're thinking of on that. It's sort of this experience of some other lesser symptoms, but you don't have that neurophysiological response.
So you can't have like the flu symptoms without actually having the flu. It's gotta be something neurological.
Correct, yeah. Yeah, we might be more in the somatic symptoms disorder. I think my wife's okay with me sharing this, but she had some physiological symptoms, some stressors. She had angioedema, swelling, some parts of her face that were brought on by some stressors in her life, and like she would just have these random swelling. Like at first she's like, shit, am I allergic to something? Because like half of her face would swell up, like just like half of her lip, started getting really thick and stuff like that. So for a while she's like, it's a seafood allergy or something like that, because it's the first time it happened shortly after we had some shrimp or something like that. It was a psychological stress that she was going on. As soon as she identified it and sort of let go of that psychological distress, it was somebody that owed her a bunch of money that wasn't paying her back, but it was really kind of weighing on her. And then she's like, screw it, I guess I'm not getting that money back. Like, now I'm okay with it. Symptoms went away, she hasn't had it again.
So how does that differ from like someone having a stress reaction? Because I know some people like get rashes or something.
Sure.
Stress hives. Yeah. Stress hives.
Yeah.
Like how does that differ?
Yeah, that's a sort of a more minor version of when we look at those medical conditions that are exacerbated by psychological distress. That'd probably be more in that category than the neurophysiological. This is obviously a very severe one if you can't walk kind of thing. Would treatment look any different than kind of what we talked about with the last one? It kind of talked about treatment a little bit in the video there, right? What do they do for treatment?
Probably more physical therapy.
They still have to address sort of these functional limitations that come about from it. So, there was some rehabilitation work that was going on. But the psychological component is like, hey, trying to see like, hey, what is the underlying, is there an underlying stressor, and what is that stressor? How can we develop some new coping mechanisms? And sometimes it can be really complicated if you don't know what it is.
What happens if you can't find it? Does it just go away at some point?
Yeah, it may just go away, kind of like, you know, over time. And this is true for other psychological disorders, even like things like depression and stuff like that. For a lot of people, it just kind of goes away after some time. But you're probably more prone to it reoccurring if you don't address the underlying issue, kind of thing. So in this case, yeah, if you don't deal with it, she's probably going to be more prone to, you know, re-experiencing it again. For my wife, like if she starts getting like a little bit of swelling or something like that, she knows really quickly, and I was like, oh shit, I'm stressed about something. I'm gonna take care of that. So it can, like, for you even, like, you know, if I get that backache or something like that, it's like, oh, you know, I'm getting a little bit tense about something. What is that thing I'm tense about? This is an extreme version of that. And they're probably more likely for that to reoccur. So you just have to be really careful with your stressors as they come about. Yeah, good job. Yeah, so we have neurological types symptoms. They look like neurological symptoms, but sometimes they don't really kind of line up with even the way that your neurology works. We'll take a look at one type here in a minute, but it isn't wanted or produced kind of thing, and that is an important feature of this. Also, we're looking at like either the factitious disorder or it's something that is intentionally created, those kind of things. So one of the reasons that, like, we know, for example, the conversion disorder is that your nerves don't line up with what is experienced. So in glove anesthesia, people lose sensation in their hand, and where they lose it is kind of where you would wear a glove. So from this point up, if there was nerve damage, that's not what it would look like. Because of the way that the nerves work, you would lose sensation in this spot or in this spot, maybe both spots, but not the cutoff of where it is experienced. Does that make sense? So that sensation of numbness is real, it's experienced, they can test it, but it is not something that is caused by damage specifically to those nerves.
So would that be caused by stress also?
Yeah. Yeah, this would be a type of a conversion disorder called anesthesia.
So is there like other things that could cause it besides stress?
Like what? What do you mean?
Like a response to trauma or something?
Yeah, a trauma could be, yeah, absolutely. That would be, you know, a stress response, I would say. Kind of fits in that. Yeah, so it doesn't have to be like being overwhelmed or something like that. All over that today, I think. So we have different versions of these. Some experience more as pain, just sort of these different subtypes that exist. Typically long lasting, she said, you know, the one I think was 4 months, the other one was kind of going on a year. With the somatization disorders. All right, let's see. I think we talked about that one sufficiently.
Would phantom limb be a part of that?
Now, phantom limb is when you lose a limb, like if you're amputated either purposely or accidentally, and your brain still is experiencing the sensation from that. Yeah.
So there's something there in that case for that.
Yeah, because you still, your brain, like if I lose my hand, for example, the brain part that is still experiencing, you know, where your experience of sensation and movement this process still exists. And so we have neuronal activity in that area that is experienced by the individuals, like as maybe an itch or something like that, which
So
that
your brain
would
would
suck,
still
right?
feel the itch.
Correct.
That,
Yeah.
That's what's causing like the pain.
Sure. Yeah, you can have phantom limb pain, or an itch, or like an experience that it's moving, or that it's there kind of thing.
So when people,
That's because your brain.
So when people are like,
is still there.
if you amputate like your arm or your leg, would it hurt? When people say that, like that's what you want to say. Because people would be like, if you get amputated, where would it hurt?
Oh, yeah, because pain is experienced actually in the brain, right? That's where you experience, like, sometimes the sensory sends a signal to the brain to experience it, but where you experience the pain is actually in your brain. You don't experience it in your limb. Now, it feels like it's in your limb because that's what your brain is saying. It's learned to associate, okay, this part of your brain is responsible for pain in your hand, but you don't have to have a hand for your brain to experience it. So yeah, is this the same as conversion disorder? I can see the relationship between the two, because your brain and your body, they're obviously connected. So your brain can make stuff happen in your body as well. Obviously, I want to move my hand. It starts in my brain.
Other side.
Ah, good job, good job. Good point, good point. All right, so why does it occur? Sort of psychodynamic views are, hey, there's some underlying things happening in your unconscious, and I think even that one doctor kind of talked about saying, hey, there's something going on in the conscious outside of at least the person's awareness. Now, if we kind of go in all Freudian on this, it's, you know, because of these sexual repressions, that kind of thing. The new psychodynamic approaches don't say that. They disagree, like, no, it's not. These unconscious sexual urges for your father is what Freud would probably say that was going on with her. She has to repress that, and the way that it's coming out is that she's placing it onto this physical limitation or
So that's what
detention. That's what Freud would say. That's not what the modern psychodynamic approach is saying. They're just saying, like, hey, the anxiety turns into, you know, maybe a pain disorder or those kind of things. Cognitive behavioral view, I think I mentioned this a little bit ago, is sort of, we talked about the rewarded piece of that, like what does the person get out of it? It hasn't been tested that much, and so we don't have a lot of evidence for it. I think another version of this is sort of that expression of that pain. I can't say it in words, maybe. I don't know, have you ever experienced pain that you just can't, like, how do you share that? How do you share the severity of a loss or a trauma with somebody that there's not enough words for it?
It's kind of like putting a number to it on a scale of 1 to 10.
Yeah. Yeah, 10 isn't sometimes enough, right? So it's so, you know, it's so bad that, hey, I'm communicating to the world that, hey, something's wrong with me, or my body's communicating maybe with me. Like, hey, this is really bad, you know, you have to do something about it. Yeah, what do you think about that? Why do you think this exists?
The brain does it on purpose, so it's gonna have some reason.
Yeah, the brain is doing it for some reason.
Probably some protective.
Some protective mechanism, sure. Like, hey, you know, the trauma is such that I can't deal with it, so, you know, maybe this is limiting in some sort. Absolutely. This is a handy little table. I did post the PowerPoint, it's on there. But when you come to the diagnosis portion, again, this might help you figure out what questions to ask, right?
What is malingering?
Malingering is faking it, so it's voluntary control of the symptoms. So if somebody actually could feel it, but they said that, hey, I can't feel my hand, and then you poke them and they're like, ow. Oh. They're manipulating those symptoms. Same thing with the factitious disorder, right? That person is intentional about creating the symptoms. Maybe not the specific ones, like, hey, that's my bladder, but they are involved in it. It's something that is desired there. Linked to a psychosocial factor, malingering says maybe. I would probably lean more towards yes. But maybe it's just like, I don't know, depends on how you, I guess, define psychosocial factor. Is it attention seeking, that kind of thing? The hard part still is, I guess, between these three, right? Is there an apparent goal? Like,
Factitious because you need that care.
yeah, I'll probably have that asterisk. So, yeah, factitious disorder, getting that attention, right, from the medical care seems to be a factor in that. You brought this up earlier, that multicultural view, that what would be the factors that would impact on a cultural level whether there are more somatic disorders? We kind of talked about it right in the beginning, but after having watched this and seen some of these, what kind of plays into that?
High stress areas
You think so? The high stress?
would be more likely to have more somatic symptoms.
Yeah. What do you think the high stress area was for the girls that were watching, the young girls? And it's pretty typically diagnosed in that age group.
Well, one thing I noticed was that there was only one parent.
Okay.
So maybe that.
Okay. So the amount of emotional support, perhaps? Okay.
Or like if there was like a divorce or something.
Yeah. Yeah. We do see more somatization in Asian cultures, for example. Again, I think sort of the stigma around the expression of psychological distress probably has a lot to do with it. I think you guys did a really good job on sort of saying that, hey, we need to look at the cause. Why is this there in the first place? And address those issues, those connections, parenting issues, those kind of things. Drug therapy, what do they mean by that? Drug therapies?
A whole lot of drugs.
What's that?
A whole lot of drugs.
Give them a whole bunch of drugs. What kind of drugs might you prescribe?
There's gonna be an underlying like depression aspect to a lot of these, so like, you know, some like SRIs or like maybe
Yeah.
to see if it helps, you know.
Yeah.
Kind of,
You'd probably see some SSRIs, right? Again, because you love that part. Yeah, looking at sort of the depression or anxiety, and probably the anxiety medication. We see a lot of overlap with some OCD symptoms. Sometimes, I'll put this right together with the OCD presentation, because it can be sort of an obsession on very specific parts of your body. Illness anxiety disorder. This is another one that's been renamed from, oh gosh, what was this one called before anybody know? Yes, thank you. Hypochondria, yeah, where'd that come from? That's good, yes.
Anxiety about having your getting significant illness.
Yes, yeah. Do you think I see this a lot in practice?
Probably.
What's your guess?
It seems like a normal,
Like worried about getting sick?
Yeah,
Seems
like
like,
normal.
yeah, especially lately, maybe. So one of the diagnostic criteria of this is that it can't be better explained by another disorder like generalized anxiety disorder. So I would, if that wasn't a criteria in there, I would see this probably way more frequently than I really do. I see a lot of folks that have generalized anxiety that also kind of focus on maybe some physiological symptoms, because there are physiological symptoms that come along with anxiety, and a lot of times like, oh, is that like a heart condition or something like that along with it? You know, a lot of times, like especially with panic disorder, people show up in emergency rooms, right, thinking that, hey, I have a heart attack. So a lot of times the attention can be, I think, especially focused on the heart. But because that is better explained by either the panic disorder or the generalized anxiety disorder, they wouldn't get a diagnosis of illness anxiety disorder, which is still part of that other diagnosis. Yeah, so you got people that spend a lot of time sort of focusing on their health. Can you think of folks like that?
Yes.
Yeah. Do they typically show up in practice, you think? Would they show up for counseling?
No.
Probably not, right? Because that's not what they think the problem is. They think it's a medical concern. It's like, no, this is real. No, absolutely. So that's probably another reason why I don't see a lot of it, really. Probably should see more of it. Probably be good, but to help somebody understand that, hey, you know, no, this is an illness anxiety disorder, they probably wouldn't be very convinced, right? It's like, no, you don't actually, you're good, you're healthy, you did all the panels, you're good. Where do you think they see this? Who sees this a lot, like professionally?
Probably doctors and nurses.
Yeah, primary care doctors, specialists, you know, that like, oh, I swear this is what I have. Probably Google didn't help. A lot of times it starts in early adulthood, same among men and women. Again, overlap with the OCD, focus on rather than, you know, hey, this is, you know, I have to engage in this behavior, but I have to pay attention to these physiological symptoms. How do we treat it? Drugs and a lot of CBT again. We probably see a lot of overlap between the two. Then this last one I think is super important as well. What are we doing on time? 10 minutes, okay. Perfect timing. They're a little bit different than those factitious. Those physiological symptoms that you are the sort of on the milder sense of things, maybe the backaches, the ulcers, gastrointestinal, restless leg syndromes, irritable bowel syndromes, all those are things that can be impacted by psychological factors. It can be very, doesn't have to be very mild. I mean, even like feeling sick and those kind of things. They'll have a medical condition, but the psychological factors have an impact on those things. So what does that mean for treatment?
Easier stress.
Yeah,
That's going to be part of the treatment. You have to treat the physiological aspect, but also the psychological aspect, absolutely. So, which is kind of weird, right? If you've got IBS, you probably should see a therapist. But it's pretty true, actually. Like, you know, hey, what's going on during the time that you have flare-ups? A lot of times we do see stressors going on during that time. So things like ulcers, asthma, insomnia, headaches, you guys talked about that, hypertension, so the high blood pressure. This is sort of what people do when they feel stressed. Watch TV, go to the internet, talk to family, tweet.
Percent, only 1%.
Yeah. What do you think? What do you do when you get stressed? Go to the internet? Yeah.
Watch TikToks.
TikTok? Is it on here?
It's
Too-
newer
It's
than-
too old, it's too old, I think, yeah.
It would've been musically back then.
Yeah.
I drink wine, that's funny.
Drink wine? Let's start right here, you're in the 26%. They're not mutually exclusive, you can drink wine and exercise. I think that's a thing, right?
What?
Yoga and wine or something like that?
Yeah,
Oh,
you
yeah.
gotta have yoga classes where you have wine.
Tweet 21.
I do yoga, I enjoy yoga a lot.
Exercise. Maybe meditate, kind of go in there. Yeah. What's stressing you out? What's stressing you out? What's not stressing you out? Everything's stressing you out?
The state of the world, school,
State of the world?
potential jobs.
Spring coming up.
Jobs.
Yeah.
Spring coming up, that's stressing you out?
Yes.
Having to.
Spring semester or like spring the season?
Like semester.
Okay. Selecting classes, those kind of things. Let's see what's stressing you out. Hold on, I'm gonna go to one more thing. Do these questions about stress. Most stressful life, President? Death.
Death is number one.
Yeah, for both, yeah. Death is hard on people. And we've had a lot of death. Like, where are we at? 800,000? In the past year? A lot of tests? That stress you out? You got a lot of tests? No, that's good.
4 out of the top 6, that's something to do with school.
Finals week, assigned to graduate school, victim of a crime. That'd be stressful.
Breaking up with your boyfriend, is that what that says?
Boy or girlfriend. Breakups are hard on college students. I don't care.
Are you a therapist? I don't want to investigate.
About my own breakup. I haven't broke up in a really long time. 15 years. I haven't had a breakup in 15 years. It's amazing. No longer than that, I guess.
Yeah, 'cause I guess
I didn't like go from one relationship to the next, so.
properties.
17 years? I haven't had a breakup in 17 years. When was your last breakup? Lots of deadlines? You guys have lots of deadlines? How do you cope with it?
Do it the night before you.
I know. I know.
Deadlines.
Yeah. So if you don't sort of address it, I think the big point here is that if you don't address the things that, these are real things that are really stressful. Like, do find some way to cope with it. Try to find a healthy way to cope with it. That's even, you get bonus points for that. Because if you don't, your body will. Your body eventually will just say, okay, that's enough of that shit. Like, you're staying in bed today.
Stress about all these deadlines, just bust out a yoga mat.
Yeah, just carry a yoga mat whenever you need to. Like, yeah, absolutely. All right, good job, thanks guys. I'll see you next week. How's it going?
Did you get my message?
Probably.
Yeah, it's okay.
Did I respond to it?
No.
Was it an email?
No, it was through text. It was just
Text me?
yeah, it's all